started. So welcome everybody to our telementoring program discussing substance use disorder in pregnant and parenting women. We also have Series B, which deals with the addiction and pain curriculum that the State Department has put out for all providers and medical students in GME. And then Series C will be, again, a collection of different providers and resources in the community. Today, we are really, really blessed to have Jacquelyn Starer, Dr. Starer, who is dual board certified in OB-GYN and addiction medicine. She comes to us from Brigham Women's Faulkner Hospital at the Addiction Recovery Program. And so I'm going to turn it over to her because she has a lot to tell us. So welcome all. And if you have questions, just start filling them out in the chat box. And we'll try to make sure we have some time at the end for those. And with that, Dr. Starer.
Okay. Hi, thank you. Thanks for getting up early. It's not so early out here. It's 9:30, so I'm good. So we're presenting the chapter that I co-wrote on substance use assessment during pregnancy, opioids, moving beyond screening, because screening is really screening questionnaires that have been validated and are meant to be used universally to identify people who may have substance use disorders, but once you've gone beyond that, it's important that you know what your next steps are and how to assess people, in this case, pregnant women throughout their care once they've been identified, or the ones who haven't yet been identified that were missed on screening. So we'll move to the first slide, hopefully. Okay. So as I said, the screening questionnaires are universal screening questionnaires. In this case, it would be for drug use, since we're talking specifically about opioids. And really, this has been long advocated, but I'm not sure we know what all the benefits are yet. Certainly worth doing, though, and identifying those who you can. So screening, so you've probably heard of SBIRT, which is screening, brief intervention, referral, and treatment. But the SBI part is really the more important part when you're going to be managing patients over time. Of course, you would also refer and have them get treatment if needed. So for unhealthy, can you hear me?
We can. We had to mute all to get that background music out. So we muted all and then unmuted you.
Okay, all right. So for unhealthy alcohol use, SBI has been shown to be clinically effective and cost effective as a preventive service. However, for unhealthy drug use, the U.S. Preventive Service Task Force states that the current evidence is insufficient to assess the balance of benefits and harms of drug use screening, including pregnant women. So we're not really left with advice to use validated screening tools for opioids. However, ACOG comes down a little bit differently on this, and even though it's not an evidence-based rationale, they use an ethical rationale to recommend that you do universal screening and brief intervention for drug use during pregnancy. So that's screening. And assessment, in my opinion, and when we wrote this chapter, we viewed really differently from screening, and it's much more of a clinical skill. And you should remember that, pregnant women, of course, we all know are a different class of people because we're treating two patients. And that whereas for instance, with alcohol, there's all these definitions for risky drinking and mild use disorders and moderate. With pregnant women, for alcohol and drugs, any drug use outside of appropriately prescribed medications should be considered as unhealthy use when a woman is pregnant. An assessment isn't a one-time thing. It should be ongoing throughout the course of pregnancy and the postpartum period. And we really should think of the postpartum period not as 6 weeks which is what insurers and payers consider it, but their very riskiest period for relapses is in the first year. So there should be this concept of a fourth trimester, which goes on for at least a year after they've had the baby. And remember that, you can get overconfident and complacent that you have a patient who, to all appearances, looks fine, but it's the casual user who's going to be the most difficult to identify because they can use around, they still have some control and they can use around their visits and their drug tests. So there always has to be in your mind that, someone might be using drugs, and remembering to counsel routinely regarding the consequences of drug use has been shown to be helpful in that group in reducing their use. So, what are your tools to identify people who might not otherwise, jump out at you as having an opioid issue? Referring to your state prescription monitoring program for all pregnant patients is always a good idea. Should be a standard recommendation. Where I work, they at the partner system, they finally put the prescription monitoring program right into the electronic software, so you don't have to leave your system, go to the state, log in, which is always just fraught with difficulty. So there's just a tab we can click on for whatever patient record we're in, and it'll take us right to the state PMP. So it's really made it a much simpler process to do routinely. But when you do that, you can, if a patient has reported that they are receiving opioids by prescription, you can confirm that. You can also identify opioid prescriptions that they have not reported and identify if there are other prescribed controlled substances and some other drugs of abuse, such as, I know ours includes gabapentin. I don't know if they're all the same nationwide, but other drugs that have been identified as highly abused. So you can identify anything that's been prescribed. One caveat is that at this point, you still would not identify someone who's receiving methadone because those aren't dispensed at a pharmacy, and that's where the systems get their information from, is the pharmacies. So that's still a work in progress, trying to link in methadone programs into the PMPs. So theoretically, it's possible for someone to be on methadone during a whole pregnancy and not let their OB provider know about it. But anything you do identify should be addressed with the patient in a confidential, reassuring manner. It's also important to remember, because I haven't so much lately, but I used to get a lot of consults as soon as a pregnant woman was discovered to be taking pain medication, opioids. Their provider wanted to refer them for buprenorphine or methadone. And that's not appropriate just because somebody's receiving a prescribed opioid, to assume that this represents an opioid use disorder, or to commit them to a diagnosis of opioid use disorder and to a treatment milieu setting that is for substance users without a thoughtful assessment of what the appropriate steps might be and whether there is a use disorder or not. So interviewing approaches, when you're assessing substance use disorders, hopefully it's not a surprise that patients might not want to tell you everything. So you want to pay attention to subtleties that would suggest that they're trying to avoid disclosure. Obviously, the most blatant is lying. And you might not recognize something as a lie, but you might suspect it. Or the lies might not quite match up. The story might not make sense. But, you know, short of actual lying, you'll often run into minimization, minimizing what they're doing as not important, or rationalizing why what they're doing is okay, exhibiting behaviors that discourage further discussion. They might get angry with you or irritable with you and make you very, very uncomfortable, so you really don't want to go down that path anymore. And then there's a really actual denial that the patients truly don't believe they have a problem, and they truly don't believe that there are consequences to their opioid use. So even though I'm not discussing screening questionnaires as a screening tool, the one that is recommended, that's been validated for both drugs and alcohol is the 5 Ps plus, or I like to still refer to the 4 Ps because it represents what you're talking about, which is the pregnancy, the past, the partner, and the parents. And it would actually be ideal to reverse that order and just keep it in mind as an interviewing technique, because a woman who's pregnant doesn't necessarily want to start talking about their fact that they're using drugs while they're pregnant. There's just so much shame with that and so much stigma. So it can be less uncomfortable for them if you start with a family and a partner history. And it doesn't even have to be, you know, do your parents drink or drug? You know, it can be a more casual conversation to help them relax about any possible drug or alcohol use in their parents, and then some, you know, questions about their partner. And then even moving into, well, what before you were pregnant, you know, did you use drugs or alcohol? Because those are all more comfortable areas for the patient to venture into. And of course, during the whole thing, it's important to remember to be empathetic and non-judgmental. Developing some trust and a therapeutic bond and relationship is key, because obviously if you don't do that, you can't continue to assess the patient, because there's a higher chance the patient isn't even going to come back to see you again. There's also, when you're assessing other red flags, such as legal red flags. Some are very obvious, some are maybe a little less subtle, I mean, a little more subtle. So any history of, you know, violent behavior or disturbing the peace, assault and battery, prostitution, history of driving under intoxication, while intoxicated, operating while intoxicated, any child custody problems, any restraining orders, theft, and obviously drug possession or sale. Many of those issues are going to involve drugs or alcohol, even if it isn't stated explicitly that it's a drug or alcohol related event. And then, of course, other risk factors would be psychiatric comorbidities or symptoms, depression and anxiety, post-traumatic stress disorder, and history of abuse, sleep disturbances, memory problems, difficulty concentrating, suicidal ideation may either be at the root of people using drugs and self-medicating, or the result of you using drugs, and that they can't concentrate, that they have memory issues, it can aggravate suicidal thinking. And then behaviors. When you have most women want to do what they are supposed to do when they're pregnant, and if they're clearly veering from that path, that's a red flag. So if they come into prenatal care late, or they have no prenatal care and just present around the time of delivery, if they have frequent missed appointments, if their behavior is erratic, if they appear on visits with you to be either sedated or euphoric. Euphoric's harder to pick up on because it just seems like a happy patient. Intoxication, withdrawal, or poor weight gain, these could all be possibly signs of drug use. And the history of the obstetrical history and the neonatal history, and this isn't all inclusive, and neither is it diagnostic by any means. So the most specific one would be if a previous infant had neonatal withdrawal syndrome. But other obstetrical events are present in higher rates in women who use drugs, which is low birth weight, premature birth, placental abruption. But obviously, those are not diagnostic of drug use. You want to look for physical signs, and for opioid use, you're primarily looking for signs of injection. And of course, not everyone is using by injection, but when they do, there's usually some evidence on the skin of needle marks, track marks, inflammation, cellulitis, abscesses, and they can be old abscesses, old cellulitis, looking for signs of chronic inflammation, or old track marks or needle marks. You also should be very familiar with signs of opioid intoxication. So there's mild intoxication, which might be difficult to pick up on. This is what I was referring to before. A patient may be feeling euphoric, may just be very talkative. That's referred to in slang as soapboxing, like they're up on a soapbox talking to people. Their sociability is increased, so they're going to be very pleasant, and they're stimulated, so they may have increased activity. And this is counterintuitive to most people who are not familiar with it. We always think of it as sedating, but it actually isn't at the mildly intoxicating doses. But you will see meiosis, which is constriction of the pupil. So pupil exam is always an important part of an exam when you're thinking of opioids. With excessive intoxication, then you get the more classic symptoms of the patient might be sedated or nodding off. Their eyelids might be drooping. Their respiratory rate may be depressed. And of course, if anyone experiences some sort of overdose during their pregnancy, that's certainly a major red flag, I mean. And opioids aren't used in exclusion of other drugs. Many people, including pregnant women, when they're addicted are really not that different than other people, use other drugs. So you want to look for signs and symptoms of other drug use, which could be alcohol in the breath, signs of liver disease, poor dental health, tremor, changes in speech, changes in pupil size again, bloodshot eyes, sweating, or restlessness. So part of assessment, some women who are being properly treated, who have been diagnosed with an opioid disorder, are hopefully going to be on opioid agonist treatment or medication-assisted treatment. I didn't really go into Vivitrol here because that's not, which is naltrexone, an opioid antagonist, because that really hasn't become mainstream, and there's not a lot of evidence yet, although it's building. So the two drugs that they may be on would be buprenorphine with naloxone, which is the brand name Suboxone, and or methadone. And the standard of care is still maintenance as opposed to tapers or withdrawals, mainly because medically supervised withdrawals have high relapse rates. And as an OB provider, if that's what you are, you should consider yourself part of the opioid agonist treatment team. You can play an important role, you know, in the team. And you should always try to have a signed CFR 42 Part B compliant release form that allows you to communicate with any of their prescribers, so a buprenorphine prescriber or a methadone clinic. And as I mentioned before, methadone dispensed in a clinic will not appear in the PMP in most places at this time, and things may be changing. You also don't want to assume just because they're in treatment, you don't want to be like, oh, okay, great, they're on, you know, they're on buprenorphine, they're on methadone, so they must be doing fine. You know, people in treatment aren't always doing fine, so you don't want to assume that the patient is compliant. You want to assess them as you would, you know, any other patient who might be have an opioid use disorder, and you have the opportunity to confirm how they're doing when you have these release forms in place by communicating with the providers. The next way of assessing, which is always what people want to turn to the quickest, it seems. Well, if I give talks, that's always what the knee-jerk response seems to be. Can't we just do drug testing? Well, it's really recommended that you have written and informed consent, or at the very least an opt-out. If you're going to make it universal, that they have an opportunity to opt out. You should be familiar with ethical principles in that by doing drug testing, the benefits should outweigh the harm. And that the ethical principles mainly revolve around autonomy, beneficence, non-maleficence, which basically mean the patient has the capacity to make an informed decision, the beneficence that you're doing the right thing when you drug test, and non-maleficence is that you're not doing any harm by drug testing. And also remember that drug testing is you know, fraught with potholes. There's all different kinds of testing. They can be misinterpreted and the results can be misused, such as in child custody cases, legal cases, criminal charges. So when you're doing drug testing, you should keep all that in mind. You should also have some basic knowledge about drug testing, and I'm not going to go into great detail, but the most common, the language is so confusing too about, you know, screening for drug use and then drug screening versus drug testing, because drug screening is not the same as screening for drug use. So that's incredibly confusing, and I wish we had better language. Because screening, to remind you, is the use of a universal use of a validated screening questionnaire. Drug screening refers to the kind of laboratory test you're using. So screening tests are the most common. They're generally urine immunoassays, and those have significant rates of false positive and false negative because it only identifies the drug class, not the specific drug. So some drugs don't show up when you're just testing for a drug class. And there's a lot of interactions with false positives when other substances might be present, other medications. So drug testing refers to a test that is confirmatory, being that it's a different method. And here the language is also confusing because sometimes if you ask for a confirmatory test, they just repeat the some labs will just repeat the screening test, and that's not what you want. So you want to be sure that you're not just repeating the screening test, but that you're actually getting a definitive test, which is GCMS, gas chromatography, mass spectrometry, or liquid chromatography methodology. And those identify the specific drugs only. You want to be familiar with what drugs are being included in the panel that you're ordering, and which drugs might require special testing. It's not easy. So, you know, if you don't, almost everyone has to ask for help, even, you know, specialists in this area. We don't get it right. I've sat in a room with, you know, a dozen experts and reviewed, you know, some drug test results, trying to make some decisions, and you get, like, you know, at least half a dozen different opinions on what a specific drug test may or may not mean. So don't feel, you know, that you're the only one who doesn't totally understand how to work with drug testing. So diagnosis and terminology you should be familiar with, remembering that the old abuse and dependence terms were replaced by opioid use disorder in DSM-5. There's mild, moderate, and severe based on the scoring criteria. There's 11 total criteria with 4 different categories, which include impaired control, social impairment, risky use, and pharmacologic criteria. But remember that, I mean, and this of course isn't really for pregnant women, because we just regard any use as risky use. But classically for diagnosis, there needs to be a recurrent pattern. And then beyond all of that, there's additional diagnostic descriptions to make it even more complicated that include early remission, sustained remission, partial remission. So nothing is black and white, it seems. So really in summary, there's no red line that separates initial universal substance use screening from ongoing assessment and monitoring. And pregnancy is a time of motivation and provides opportunity to identify and to treat. But the only way you can assess, identify, and treat is if you build trust through confidential and non-judgmental medical care. So the next thing would be case discussions. I don't know, Maria.
Yeah, that's great. Thank you for that. That was an awesome kind of overview in exactly where we want to make sure our participants are understanding. And like I said, we had done some past screening, and I love how you just went in a little bit deeper into the assessment. So